All right, so I don't know how many people we have, but anyway, I would like to thank you for being here after hours to learn about colon polyps. And I will be focusing on large colon polyps, as Sue was mentioning, and what we can do at Baystate Medical Center to remove them. So I'm going to go next. All right. So because this is a really advanced talk, I wanted to start with some basic definition, assuming that some of the audience might not have a very advanced medical background. And then we'll talk about some symptoms and how to prevent colon polyps and what are the screening recommendations, and I will be focusing mostly on endoscopic resection or how to remove the polyps endoscopically. So first, we're going to start to define the colon. What's the colon? The colon is basically a hollow tube-like organ, and it's the last part of the GI tract or the gastrointestinal tract. And it connects to the small bowel over here, and then it connects to the anus on the other end. And it has several portions or several parts: the cecum, the ascending colon, transverse colon, descending colon, sigmoid colon, and rectum. To understand better how we resect polyps, it's really important to talk about the different layers of the colon wall. So if theoretically, if this is a colon, and this is the lumen, you have the mucosa, which is the first layer of the colon wall, and this is where the polyps come from. And then you have the submucosa, and this is a space where we frequently inject when we are trying to remove a polyp. We inject some fluids to expand this space and to lift the polyp away from the third layer, which is the muscle layer. And this is basically the layer that you do not want to injure. This is the layer that if you poke a hole in it, it's basically a perforation. Okay, and then you have a very thin layer we call serosa. And then what is the colonoscope? The colonoscope is technically a tube that has a camera in the tip of it. And we use this tube and the camera to look inside an organ. So when we are looking inside the colon, we call it colonoscope. And then in the tip of the colonoscope, you have this nice camera, high definition camera. And then you have two lights. And then you have this channel that allows us to do stuff in the colon. Okay, we can insert instruments through it, and we can suction polyps from it through it. And then you have this other channel where we can inject fluids or water to clean the colon. What's colonoscopy? So colonoscopy basically using the colonoscope to look inside the colon. That's the process, right? The patient will be completely asleep. The patient will be laying on his or her left side with both knees and hips flexed. And the endoscopist or the physician who's doing the procedure, we call it endoscopist, will be inserting the scope through the anus into the rectum and all the way up to the cecum while looking at the monitor in front of him or her. The colon does not look like a flat tube, like you can see here. It has a lot of folds, it has a lot of turns, right? So very frequently, or not very frequently, but like always, I tell my patients that small polyps can always be hiding behind folds. So for example, this is a fold, right? You can't see what's behind it. And that's when we can miss polyps sometimes. And I always tell my patients that when I'm obtaining a consent. So what's the colon polyp? So the colon polyp is a growth that comes from the first layer of the colon wall, which is the mucosa. It can be very small, just like this nice small polyp, which roughly probably like 5 millimeter in size. For those who don't know the metric system, 1 inch equals 2.5 centimeter, and 1 centimeter equals 10 millimeter. Okay. So the polyp can be really small, just like that one, or it can be larger, just like this one, or it can be massive, Okay. Usually, the bigger the polyp, the higher risk to turn into a cancer. Now I'm going to talk about some tools so you understand later how we remove those polyps. So a snare, what's a snare? A snare is basically a metal wire that has an oval shape or circular shape, it depends, where we can put it around the polyp, just like this, and we close it until we cut the polyp completely. The polyp, the snare can be cold, means there's no heat in it, or it can be hot. We call it hot snare because there's heat in it. And the heat will help cutting the polyp. If the polyp is really big, it can also help burning the blood vessels so the patient does not bleed while we're cutting the polyp. And then there is this knife. This is not like a sharp knife that we see in the kitchen, but it's a metal part that cuts with heat. Okay, and then if you can focus here, you can see this small hole here where we can inject fluid through the knife into the tissue, into the submucosa that we talked about earlier. And then we have the injection needle on the left. It's just like a needle where we can inject fluid into that submucosa to lift the polyp up. Or we can also sometimes use it to place a tattoo. Just like the tattoo we see on the skin, we can also tattoo inside the colon. And the purpose of the tattoo usually is for future reference. So sometimes when we remove large polyp, we want to follow up on it in 6 or 12 months to make sure it's not coming back. And when the polyp site or the polypectomy site heals, it can be difficult to find. So we place a tattoo just to make sure we are at the right spot. And then you also have what we call retrieval devices. After we remove the polyp, we need to take it out of the colon, right? So the pathologist can look at it under the microscope and tell us whether it's cancer or not. So we have two retrieval devices. We have what we call rescue net or Rothnet, which looks like a snare, but it has, if you look carefully, you can see there's some mesh in there. So we close it on the polyp and we pull it out of the colon. And also you have the forceps here where you can also close on the polyp and pull it out. So I'm going to move on to talk about the symptoms. What are the symptoms of polyps? Most of the time, colon polyps are asymptomatic, okay? And that's why sometimes I struggle with some patients who I try to convince them to do screen colonoscopy. The first answer I would get, I feel fine. I don't have any symptoms. Why do I need to do screen colonoscopy? So colon polyps most of the time are asymptomatic. Sometimes when the polyp gets really big in size, it can bleed. Very rarely, patient can have a change in bowel habits or even obstruction, complete obstruction of the colon, unless the patient has a cancer. So once the polyp turns into advanced cancer, then patients will have some obstruction or narrowing of the lumen that gives abdominal pain, nausea, vomiting, stuff like that. But most polyps are asymptomatic, especially when they are small. How to prevent polyps? I think I wrote that sentence a little bit wrong. I should say how to decrease the risk of colon polyps, because really there's no good way to prevent colon polyps. Okay, there are some risk factors that can put a patient at a risk for colon polyps. That's why we recommend healthy diet. Eat less fat, eat less red meat, more vegetables, fruits, and fibers. And we always recommend weight loss. Obesity can be associated with colon polyps. Avoid smoking, which is a big risk factor for colon polyps, but also other diseases in the body. And also, we recommend limiting alcohol use. So the reason I said we should say how to decrease the risk, because I have seen in my daily practice, I have seen patients who are fit, don't smoke, young, healthy, eat very healthy diet, and they develop large polyps. On the other hand, I have seen patients who are like really old, who are obese, smoke every day, drink alcohol heavily, very unhealthy diet, and they don't have any polyps. So this does not prevent polyps per se, but it decreases the risk of polyps. For screening, the screening is the best way to prevent those polyps from turning into cancer. So currently, there are several modalities, several ways to screen for colon polyps. Colonoscopy is my favorite. With colonoscopy, you can find the polyp, but not only find the polyp, but you can actually remove the polyp. The current guidelines recommend starting screening at age 45. In the past, it used to be 50, so it's not 50 anymore, it's 45. Sometimes if the patient has a family history of colon cancer in the parents or in older siblings, the recommendation might change, and we might recommend doing colonoscopy at age 40 instead of 45, or even sooner than 40. There are also some other tests, such as stool tests. Probably you have heard fecal occult blood test or like FIT test. Those are very simple stool tests that we can do. The downside of those tests, they are only for diagnostic purposes. They cannot be used as therapeutic. So whenever the patient gets positive FIT test or positive fecal occult blood test, then the next step would be to go back for colonoscopy. So that's why, plus those tests, I mean, there's always sometimes when they can be false negative or even false positive. So to me, I always recommend colonoscopy unless the patient really doesn't feel strong about doing it. So rule number one, most polyps, no matter how big they are, can be removed endoscopically during colonoscopy with absolutely no need for surgery unless there is advanced cancer in the polyp. And you notice that I highlighted the word advanced because nowadays we can still remove polyps with early cancer using the scope only without a need for surgery. So I'm going to start to talk about how we remove polyps, right? So the first technique we do is polypectomy. What's polypectomy? So ectomy means resection or removal or cutting, and polyp is, you know what the polyp is. So we remove removing the polyp is called polypectomy. How do we do that? If the polyp is small, just like the one in the picture, you can just put a snare around it, and then you close the snare and you cut the polyp. Those pictures from procedure I did this morning, you can see a very nice hiding polyp over here. You know, I put the snare, and this is as I told you before, sometimes polyps can be hiding behind folds, just like this one. But I got lucky. I was able to see it. So you put the snare around the polyp, and then you ask your assistant to close the snare, and then the polyp will come off. Sometimes patients can have some bleeding, like you can see in the right lower corner, but usually the bleeding stops on its own. We use this technique using the cold snare for polyps that are like really small, less than 1 centimeter or 10 millimeter. Okay. What do we do for large polyps? So there are several techniques for large polyps. So we have endoscopic mucosal resection, we have, or EMR, we have endoscopic submucosal dissection, or ESD, or we have hybrid ESD where we mix between the two techniques. And then finally, we have endoscopic full thickness resection, or EFTR. Those are really cool techniques. I'm going to go talk about them in details one by one. So I'm going to start with EMR. So what's the concept of EMR? How do we do EMR? So in this nice figure, you can see here in picture number one, we use a needle to inject fluid. This is a fluid that is mixed with the dye, basically saline or sterile water mixed with the dye, methylene blue, usually we use. We inject it in the submucosa. So you have the polyp here that is coming from the mucosa, right? And then you have the submucosa over here. This space can expand, okay? And then you have the muscle. Why do we inject? Because we want, when we want to cut the polyp, we want to be as far as possible from the muscle so we don't cause injury to the muscle. Remember, the muscle is the layer that you do not want to cause injury to, right? So after we inject, here you put a snare around the polyp and we cut it off, and then we pull the polyp out with the tools I explained before. All right. So great technique, fast, very helpful, very safe, but it has some difficulties too. So this is a polyp that I removed a few months ago, actually more than 3 months ago, maybe like a year ago. You can see this polyp larger than 1 centimeter. Probably I would estimate 1.5 or 2 centimeters. After we did EMR, the polyp was removed. So when we remove a polyp in one piece, we call it en bloc, okay? It's always better to remove the polyp en bloc because that will decrease the risk of regrowth, okay? And you can see how the polyp is lifted. You can see this blue dye I injected here, right? And the polyp is gone. And about 6 months later, this is where the site is. You can see there's some scar tissue there, but it's like the polyp never existed here. All right. This is great. EMR in a block, perfect results. Patient will do very well, will never come back. Okay. Now the problem, and this is also another example. You see the polyp here is a little bigger, is more flat over here. Those polyps sometimes can be difficult to see, and they can be actually missed. And then here, after I put the snare around it, and then after we cut, very nicely removed in one piece. This is where the defect is, and this is the specimen. And this is after we remove the specimen, approximately 2 centimeter in size. Okay, so EMR works perfect here, but when the polyp is really large that you can't fit in a polyp in a snare, because we have the biggest snare we have is approximately 3 centimeter, a little bit more than 1 inch, right? This becomes a problem. The reason is, as I'm showing you here in this cartoon. So you have this polyp. This gray thing is a polyp, right? Large one. You cut the first piece. You cut the second piece, third piece, fourth piece, or etc. Right? It's a great, but the problem is in those areas that they were not resected. Sometimes those areas, most of the time, if I see them, I can keep cutting, okay? But sometimes they can be difficult to see. Remember, when we start cutting, patients might bleed, the shape of the polyp will change, so it can be difficult to see. And most of the time we actually burn the edges of the resection just to make sure the polyp doesn't come back. So this technique called EMR, but we are removing the polyp in piecemeal fashion, in pieces. We're not removing the polyp in a single one piece. So it's still a good technique. It's still I can use it very frequently. For example, this patient had this large polyp. The polyp here is actually the entire thing. This is in the rectum, okay? So this is in the rectum. This is the scope. If you're wondering how are we seeing this, this is the anus here. So the scope is coming into the rectum, and we are looking like this. This is what we call retroflexion. So we're looking backwards. So if this is a scope like this, I don't know if you can see my finger, but then we're looking like this. So this is the retroflexion in the rectum, and the polyp is the entire area. Okay, this whole area, all what you see pretty much is a polyp. Okay. So this is after resection. You can see it's the entire circumference is removed. And this is with retroflexion. This is forward view. This is retroflexion. You can see the entire circumference is removed. And I also burned the edges. You can see here the white line here at the edges, just to decrease the risk of recurrence or regrowth. And this patient got lucky because this is how it looked after I brought her back 6 months later. Very nice, very clean, no definite evidence of regrowth, right? This is great. Now, this is not always the case. So this is another patient where was referred to me, a very nice woman referred to me with large rectal polyp. This by far is the biggest polyp I have ever seen over the last 7 years since I started doing GI. So you can see here, the polyp is all this, all this, all this, all this. In fact, I could not fit the polyp in one picture. And this is in retroflexion. I could not fit the patient polyp in one picture. This is how big it was. It actually took me approximately 6 hours working on this polyp. And this is how it came out. This is after the resection. We actually filled 2 jars. This is like really large, guys. This is probably, I estimated it to be like maybe like 20 centimeter approximately. All right. So in this case, after I brought the patient back, there's recurrence. There's this, this. Those are most likely the areas where I told you, when 2 resections don't overlap very well, and I could not see it. Not a big deal. I removed them, brought the patient back. She should be good. Okay. So now I'm gonna move on. So as you can see, EMR, great technique, takes a short time unless the polyp is like massive like this one. Pretty safe. The recurrence rate can be high. And now I'm gonna move on to the second technique. And this is an endoscopic submucosal. This is a typo. It should be dissection, not resection. So ESD. So with ESD, the way we do this procedure, we use a knife, just like the knife I showed you earlier, and we inject beneath the polyp. We start marking the lesion with a knife. We burn the mucosa, and then we inject fluid with a dye, and then we start cutting around the polyp, and then we start cutting beneath the polyp until the entire polyp comes back in a single piece with safety normal margins, as you can see here. Okay, this is a novel technique. This was invented in Japan, and people have been practicing this in the US for the last probably like 15, 20 years, maybe. Very cool technique, but it takes a lot of time. This is an example of a polyp that I removed in the past. I think that was, if I'm not mistaken, in September last year. So a large polyp, and this is after resection. You can see nice polyp, and then the polyp was nicely removed in a single piece. It was approximately 7 centimeter. Okay. Another great technique, high-risk technique though, and I will talk about that later. And then the hybrid ESD is where we can mix between the 2 techniques, between EMR and ESD. We start injecting under the polyp, we cut around it, we start dissecting in the submucosal space, and then eventually, we grab the snare and we cut whatever left, and we still get the polyp in a single piece. The advantage of the hybrid ESD is you still get the polyp or the majority of the polyp in a single piece, but you save a lot of time because by doing the snare will take maybe like a minute to remove the rest of the polyp versus the ESD might take an hour or more. And you still get the polyp in a single piece. This is a polyp that I have worked on earlier at the end of last year. It wasn't cancerous, but it was high risk for cancer. You can also see it here. It was in the rectum. And then this is after I removed it. And this is the specimen, plus like a small specimen that I could not remove in a single piece. And this is how it looked afterwards. So the concerning part of the polyp is still removed in a single piece, in addition to smaller pieces. Okay, so you have been hearing me talking about single piece. Why? In addition to the fact that the polyp can come back if we don't remove it in a single piece, but more importantly, for those polyps that are really bulky and large, there's always a chance that there might be cancer in them. So if I remove the entire polyp in a single piece, when I send it to the pathologist to look at it under the microscope, he will be able to tell me if the cancer is fully removed or not, right? But if I remove the polyp with the EMR in pieces, imagine I can cut through the cancer with the snare. In that case, the pathologist will not be able to tell me if the cancer is out completely or not. That's the major advantage of ESD over EMR. Right. So this is a video of a polyp I removed with ESD or hybrid ESD. So here I'm injecting, I'm lifting the polyp. See the blue dye. I'm using the knife, and then I start cutting. I keep cutting. You can see how bulky the polyp is. I'll keep cutting. And then this, now I'm in the submucosal space. I'm just gonna go back so you can see the muscle fiber. So here, over here, this is all muscle. This is all muscle fiber, right? And this is here where the mucosa or the polyp. So I'm looking at the polyp from beneath, okay? And this is where the submucosa. This is where we inject, and it will lift the polyp up. Then see, I'm injecting now. Here I'm using some clips to lift the polyp so I can get a better, access to the polyp. And while I was doing this procedure, you see those muscles, and boom, you have this small hole in here. This is a perforation. This is what I was talking about. You don't want to cause injury to the muscle. So unfortunately, sometimes that can happen, but it's not a big deal usually. We close it. I close it here with a few clips. So more closure. And then here, I use the snare to get the rest of the polyp out. This is after the closure. And this is after the polyp was removed. So the biggest chunk of it is removed in a single piece, but then there was this smaller piece. The patient did well, was admitted to the hospital for a couple of days and left home just to make sure that he's stable. And the pathology results showed that there is an early cancer in it, but there was no advanced cancer. So basically, he was cured. All right, I'm gonna move on. So this is a nice, if you guys are interested in numbers, this is a clinical trial, was published earlier this year to compare between ESD and EMR. And you can see here, as we talked earlier, with ESD, the recurrence or the regrowth of the polyp is really minimal. It's almost zero, okay? Versus in EMR, it's 5%. In other studies, it's actually more than 5%. And the total complications in ESD is higher than EMR. And looking at those numbers, it sounds like it's a lot of complication risk, but most of those complications are like very minimal complications. I looked into the paper, nothing major. And the perforation risk, however, in the ESD group is higher than the EMR group, as we said earlier, mostly because I'm dealing with I'm using a knife with a free hand, so it's really can be very technical and very challenging. And then surgery for complications was not required in many patients, only 1% in the ESD group. And however, surgery was needed for incomplete resection in the EMR group in 7% versus 3 or 4% in the ESD group. So as you can see here, both techniques are good. Both techniques has pros and cons, and sometimes it can be difficult to decide how to proceed. As a summary here, I included this table. For ESD, the recurrence and the bleeding risk, I'm talking about delayed bleeding risk, would be lower than EMR. On the other hand, the perforation risk and the time of the procedure will be much higher than EMR. EMR, on average, it will take in a fairly big size polyp, it will take probably like an hour or like 90 minutes. Versus ESD might take 3 or 4 hours. So a huge time difference. And then when do we choose ESD over EMR? Okay, so when I get a referral from outside, I bring the patient to the clinic and I explain pretty much whatever I explained just now, and I will have the patient decide what would you like me to do? Would you want to take the risk of a perforation? And make sure that the polyp is completely gone and you don't have to worry about it, versus you want to be more conservative and do EMR, knowing that the polyp might come back. And I will have the patient decide. I would give recommendations for certain polyps. So for polyps that are more distal, more in the rectum, we usually recommend ESD. For large polyp in the colon, I prefer, especially in the cecum and the ascending colon, on the right side, I prefer EMR because ESD usually is more technically difficult. Now, I would still consider ESD if there are some concerning features of the polyp, such as like some depression or like large nodules. If the polyp is ulcerated, large, then those patients should go to surgery, because that most likely means that the polyp has invaded into the muscle layer and it cannot be removed endoscopically. Rule number 2, plan can change during the procedure. Many times I would discuss the plan with the patient in the clinic, and the patient decide, well, let's go with ESD. I will plan for ESD. I go to the procedure, and something happened. Either the polyp cannot be removed with EST, technically very difficult, or if I set up the patient for EMR and then I go there and I see the polyp is really, nasty looking. There might be cancer. And so I always change the plan. I always tell my patients, yes, we will decide on this, but please keep in mind that the plan might change during the procedure. And frequently it does. So now, what do we do with the defect after we remove the polyp? Do we close the defect? Do we close the polyp side, or we keep it open? There's really no good consensus of this. Some people prefer to close everything. Others do not. So usually, sometimes even if the polyp is really large, you cannot technically close it. Okay, just like that largest polyp I've ever seen. I told you that polyp, there's no way it can be that polyp, that side cannot be closed. So we do have several tools to close at Baystate. I'm going to start with those nice small clips. We call them through the scope clips. Those we can insert them through the scope and we close. They don't close very well. If there's a real perforation, they're not the best tools to close a defect, but they are nice to close to bring all the margins closer and decrease the risk, hopefully decrease the risk of bleeding later on. So this is a nice picture of a polyp that I removed on the left. And you see this nice defect. It was very well closed with a couple of clips. And this is the other clips we use. We call it over the scope clips. Why is it over the scope? Because we install the clip on the tip of the scope, as you can see on the left. And the clip will come on a cap, like you can see. The clip looks like an animal trap, just like here in the right lower quadrant. Which I really hate this because it makes me sad because it feels like it can cause a lot of pain to the animal. But anyway, it looks like that. I don't know if you can see my hands on the camera, but usually this clip will close like this. And it's pretty strong. It's pretty strong. It's very useful tool. The downside of it is you can't close big defects with this. You can close very small defects. Okay. And then we move on to this other tool we called X-Tack. Pretty much this tool is a bunch of screws connected with a thread. So we insert the screws around the lesion, around the defect, and then with this thread, we just pull it out, and the defect will close. Very cool technique. And then this is a picture from my colleague, Dr. Miller, who did the polypectomy on this patient, and you see this big defect, and this is how it was very nicely closed using X-Tack. Very cool. Then we move on. This is probably the most sophisticated, the most advanced closure device. Okay, so we call this overstitch. This is basically a suturing device. We can suture any defect, pretty much any defect inside the colon using this device endoscopically. No cut, no scar on the belly. Okay, so those are some pictures of how it works. This is the defect. You can pretty much just suture and then close the defect. We have this at Baystate, and we frequently use it. All right. So now the polyp is out, the defect is closed. What to expect after the resection? Most of the time, if no complication happened during the procedure, the patient can go home same day. They can live pretty much normal life. I will always tell them not to do meticulous, work on the same day. Legally, the patient is not allowed to drive after the procedure, so we always have the patient bring a driver with him or her, and then they can resume diet same day. Right after the procedure, we would give them some food, and then on the way home, they can stop by and eat a burger somewhere. Exercise-wise, I would tell the patient to be easy on exercise. They can still do some exercise, but I would not be too aggressive over the next, few days after the procedure. Now, if the patient got a complication like that patient I told you about where there was a small perforation, then the patient needs to stay in the hospital, sometimes overnight, sometimes for a couple of days, but usually not more than that. Surgery might be required very rarely, very rarely. If a patient is taking blood thinners, those needs to be stopped before the procedure, but also after the procedure. Sometimes patients might have, heart disease, and it's not safe to stop blood thinner. In that case, that's when the closing the defect would be really helpful because it would decrease the risk of bleeding after the procedure. Now, when the patient goes home, I would still tell the patient that if you see blood in the stool, if you develop fever, if you develop severe abdominal pain, please go directly to the ER because you might have bleeding or you might have a complication from the procedure. And then after we take the sample, we send it to the lab. A pathologist will look at it under a microscope. The report will take a few days to come back. And once the report is back, usually if there's no cancer, no major findings, I would send the patient a letter. My colleagues would do the same. Or if there's a cancer, God forbid, I would call the patient and if the cancer is fully removed, I think that's it. If the cancer is not fully removed, then we're going to have to send the patient to our colleagues from surgery or medical oncology. When to repeat the colonoscopy? We have to repeat the colonoscopy in 6 months if we did EMR. At least that's my practice. Or 12 months if I did an ESD. Okay. Or maybe sooner if there was some surprising findings like a cancer. If the patient is young, so say the patient is like 55 years old, I always tell him that your children or even younger siblings should start screening at age 40 or 10 years before the age of the patient when he was diagnosed with this large polyp. So we treat it just like a cancer, even if there's no cancer in it. Okay, and then after that, they should repeat colonoscopy every 5 years. I always tell the patient to make sure that the children's PCP and siblings PCP is aware. This is very important. So EMR, ESD, hybrid ESD, very cool techniques, right? I think you agree on this. Very helpful, but sometimes they might be useless. So, for example, this patient was referred to me from one of my colleagues for a polyp. So he tried this. This procedure was done by those pictures from procedure done by my colleague. So he saw this polyp. He got a cold snare, removed the polyp, great, right? But when he looked more closely, there was a growth inside the diverticulum. A diverticulum in the polyp, which is singular from diverticulosis. You probably heard the term diverticulosis a lot. So diverticulum is basically a pocket, out pocket in the colon, probably just like this one over here on the left side. So when the polyp grows into the diverticulum, it becomes removing it with a snare becomes difficult one and becomes risky. Number 2. All right. So this patient was referred to me, and I used this really, really cool device we called endoscopic or full thickness resection device system. We use this device to technically remove the full thickness, including the muscle layer I was telling you about, in one piece. So how does it work? So the device has this cap, and it has a clip that's already installed on it. And then you have this nice white ring that actually pushes the clip outside. And then if you look very carefully, you can actually see a snare that's already attached to the tip of this cap, okay? And then you can also insert this grasper. So how does this work? So we say this is the polyp here, number one, and then you grab the polyp and you pull it inside the cap, and then you deploy or you push that clip out, and then you cut using that nice snare, okay? And then if you notice here, you can see we cut part of the muscle, okay? So this is even more advanced. The downside of this is you can't remove very big lesions. So lesions up to like 1 inch or like 2.5 or even 3 centimeter can be removed, but not more than that. I'm gonna show you this nice video for a patient we removed that polyp using this device. So here I'm grabbing the polyp, I'm pulling it in, and then if you notice that I'm placing the clip now, and then I'm cutting. And this is how it looks afterwards. So you can see here, this is a part of the clip. Unfortunately, it's buried. You can't see all of it, but this is part of it. And you see this yellow fat tissue. This is actually the fat outside the colon, okay? And then the polyp came out, and the pathologist confirmed that the polyp is completely removed. All right, so I'm gonna move on. So that's it for me. This picture I took. We took last Saturday when I was in Texas attending this really wonderful course to learn new techniques from really like world leaders in endoscopic resections, and to learn more about new devices to hopefully bring to our hospital to keep Baystate up to date, and you know, so we can best serve our great community at Western Massachusetts. If you're wondering where I am, I'm right there. All right. If you're not wondering, that's fine too. All right. That's it for today. Thank you so much for being here. I really appreciate it. I'm more than happy to take some questions. I think we're right on time.
Wow, that was fantastic. Well done, you. What a great expertise and some amazing technology. Really terrific presentation. We do have a few questions coming in. So we invite the audience, if you have any questions, to type them in the Q&A box, and Dr. Zakharia will address them. The first one is, how do you decide what technique to use to remove a polyp?
That's very, very good question. So again, it depends. So if there is a concern that the polyp has, I'm assuming you're talking about EMR versus EST or hybrid EST. So if the polyp has features that are concerning for early cancer, such as depression, as I mentioned in one of the slides, depression or like a really large nodules, then I would choose ESD. If the polyp is in the rectum, I would choose ESD. The reason is studies have shown that polyps in the rectum tend to have cancer more than the polyps in the rest of the colon. So that's one thing I keep in consideration. sometimes the technical aspect of it. So sometimes I can have, if you have a polyp, a large polyp in the right side of the colon, in the cecum or the ascending colon. In that part of the colon, removing a polyp with ESD can be very challenging, not only challenging, but can be very risky too. So in that case, if I'm not concerned about cancer in the polyp, I would probably choose EMR. Yeah.
Very good. Thank you.
Yeah.
The next question is, do clips stay in place?
So we have two types of clips. I'm assuming you're asking about through the scope clips, those small ones. Those usually they fall off. We don't know when exactly. They can stay there for a day. They can stay for weeks. I have actually seen clips stuck in place for months or even years. So usually they fall off, but they can stay in place too. The other type of clips usually stay in place, but they can also fall off.
Is it okay if they stay there?
Yeah, they're usually okay. People worry about it because they are metal, and when a patient gets MRI, they say, you can't have any metal part. Usually, those clips are, at least the ones we use at Baystate, they are usually compatible with MRI, so the patient can safely has an MRI with no problem.
There's a follow-up question to that. Is it painful to pass a clip?
It's not. So even though in the pictures you saw the clips are really large, but remember those pictures are really magnified, so maybe times 10. So probably the clip would be this big.
Oh, okay.
So they look bigger in the pictures, but they're actually very small. So no, you're not gonna find. If you're lucky, you will be able to see it, but most of the time it's not painful. You're not gonna feel anything. You're not gonna see it.
Right, that is extremely small. The next question, what type of case would make you inclined to use EFTR?
So EFTR, I would use that when in certain situations. Okay, so sometimes just like the polyp I showed you, the polyp can be growing inside the reticulum. I would use this device because it's not safe to use the snare, at least in my opinion. Sometimes the polyp can be growing inside the appendix. In that case, also I would use EFTR because I'm not going to be able to obtain full resection when the polyp is growing inside the appendix. In fact, I have a patient coming soon to discuss that. And also sometimes I would find EFTR useful when I have a recurrent polyp, when the polyp are resected the first time, if they're not removed completely, the next time would be harder. The reason is the body will start to form scar tissue, and scar tissue is really hard. It won't lift as well, and in that situation, I can still consider EFTR. Those
Very
are the
good.
three major scenarios where I would use it.
Very
Or
good.
sometimes if I have actually I can add one more. Whenever I have a mass or a lesion that is actually coming from the lesion that's coming not from the mucosa, the first layer, but sometimes the lesion can be coming from the muscle layer itself. So, for example, neuroendocrine tumors, or like in the upper GI tract, there are some GI stromal tumors. So those are the scenarios where those techniques won't help. You need something to get deeper. That's when the EFTR can be helpful.
Hey, thank you. The next question. My daughter was 32 when she had a small pea-sized polyp. It was snared out. 3 years later, she had stage 4, had gone to her liver, and she passed at 40 years old, and she has 4 children. when should they start with a colonoscopy? And I'm sorry for your loss.
I can't see. So just tell me again. So she was 32 when she was diagnosed with colon cancer?
Yes, and she had a polyp removed, and then 3 years later, she ended up with stage 4 cancer in her liver, and she's wondering when her 4 children should start with a colonoscopy.
Sure. I just want to clarify one thing. Was she diagnosed with colon cancer that spread to the liver? If that's the case, then the answer would be, why did that happen? Like, it's very, very weird to see someone who's 32 with such an advanced cancer. We see it, but not very common. In those cases, we need to worry about mutations. Okay, so I would do genetic testing for the patient. Unfortunately, she passed away, and I'm so sorry for your loss. But maybe do some genetic testing for the patient and the children. Make sure they don't have any genetic problem. That's one. If there's no genetic problem, and in fact that it's true that she was diagnosed with colon cancer that spread to the liver at age 30, I'm assuming 33 because she said 3 years later. So the children should really start like 10 years younger than the time she was diagnosed with the cancer. But again, seeing a colon cancer at 33 is a little weird. A patient might have a genetic mutation that will require some further investigation.
Thank you. Dr. Zakharia, are these advanced resection techniques offered elsewhere in Western Mass or only at Baystate?
So in Western Mass, it's only at Baystate. For EMR, can be done by any endoscopist, even general gastroenterologist can do it. But for ESD and EFTR, those are only being done at Baystate at the moment.
Very good. Thank you. The next question, what's been the most effective approach to get someone to agree to a screening?
What is the most effective way to what again?
What's been the most effective approach to get someone to agree to a screening? I would assume a colonoscopy.
That's really difficult question. That's really difficult question. First, usually this is discussed by the PCP. So when we do the procedure, it's usually patient is convinced and they come and we do the procedure. When I see a patient in the clinic and they tell me I feel fine, I'm not symptomatic. Basically, I just explain to them. I just tell them this is what you would feel. This is why it's important. This is what we can prevent. I just talk to them. People will understand. Most of the time, when those people don't want to do screen colonoscopy, probably they don't understand what it is. They're afraid of. I have patients who are afraid of anesthesia. I have patients who are afraid to do the procedure because they're afraid that anesthesia will give them dementia. Like they are like weird things that people think about. I just explain to them.
Very good. Thank you. What's the next steps when a polyp reveals cancer?
That's a good question. So most of the time, if there's a cancer in the polyp, I will be able to tell during the procedure. Okay. What we do is we take biopsies. We send the biopsies for pathology. If it comes back as a cancer, I refer the patient to a medical and surgical oncologist. After that, we do some imaging to see how advanced the tumor is. Okay, if it's not too advanced, if surgery is the next step, the surgery it is. we have great surgeons at Baystate, and super helpful, super talented. They can do surgeries. If the tumor is too advanced, with mets will like spread to the liver or somewhere else in the body, then we send it to the medical oncologist to see if they qualify for any chemotherapy, stuff like that. If the tumor is too advanced and obstructing or causing a lot of narrowing in the lumen, and the patient has a lot of symptoms, then we can actually, as a GI, we can go there and we can put a stent and we open the lumen up so the patient can feel a little better. Usually, that's more like for very advanced cases where like was not gonna benefit from anything basically.
Very good. Thank you. Looks like it's going to be the last question. We're at time. I didn't even realize it. I apologize. Do EMR, ESD, etc., all require the same kind of prep as a colonoscopy?
Correct. Just like a regular colonoscopy, both will require the prep. I usually recommend golightly, which is like a gallon of fluids. Most patients hate. So that's what I would recommend. Now, when I mentioned, so it's the same prep, everything is the same. The one thing I would like to mention is when I'm planning to do an ESD, I will tell the patient, please make sure your stool are clear. Okay. The reason is, as you know now, the risk of perforation might be higher in patients with ESD. When there's a perforation, when there's a hole in the colon, I don't want the stool to coming out of the colon and contaminate, the abdominal cavity. So in that case, I make sure the patient understand very well the importance of the really good prep. And I spend a lot of time before I even start cutting anything. I spend a lot of time cleaning the colon very well before I start cutting, because I do not want to cause injury when the prep is really bad.
Sure. Well, thank you for your expertise and what you're doing for your patients and your time tonight. Excellent presentation. We're very grateful. And thank you to the audience for joining us tonight.
Thank you, Sue. Thank you. Have a great night.